Okay, fantastic. Should we make a start? I've just set everything up on YouTube, so that's working now.
Perfect.
I'm just going to hit the record button. Okay, could you click the next slide, please?
Yeah.
Okay, fantastic. So thanks so much for joining us, guys, and big thank you to our speaker today. So if you guys were here last week, you'll recognize Dr. Bay. He gave the first part one, lower limb for MSK. I won't spend too long introducing him. But for those of you who don't know him, he's a graduate from Imperial College London, and he's currently working in the east of England, and he's working at the James Paget Hospital in east of England. So I'm going to hand over to you in a second, Dr. Bay, but could you go to the next slide, please? So yeah, very quickly, I know Stephen's probably mentioned this a few times, but we have this giveaway. We've put a lot of time into kind of gathering all these different partnerships, and we're actually coming to the end of the series. So after today, we've just got 2 more lectures left. So the only way to kind of be in contention of winning the prize 1 or prize 2 is really just to show up. So as you guys already know the drill, I'll put the feedback link in the chat. And if you're watching on YouTube, I'll do the same thing on YouTube towards the end of the presentation. So please just fill that out. You'll just have to wait just over a week and we'll do the giveaway. We'll announce everything on social media. So big thanks to our sponsors and our partners. We use Medal and Anastomose to promote the events online. We have obviously fantastic sponsors who have given us some prizes. So Quesmed, MySuture, Os Implants, and Scrubbed In. Next slide, please.
Okay, so thank you very much, Dylan.
Fantastic. I'm just going to spotlight you now, and I will let you take over.
Sure. Obviously, if any student asks a question in the chat, which you think is very relevant for that slide, you can sort of stop me.
Yeah, sure.
At the end of that slide and interrupt me. Otherwise, I'll take questions at the end. So hello again, everyone, and thank you very much for inviting me back for the part 2 of this talk. So today, again, we'll be focusing on the upper limbs. I'll again be talking a little bit of the relevant anatomies that you need to know about, and then we'll talk about the examinations of the spine, upper limb, and hands. And today I'll be talking about the viva cases after each examination. So I'll do the spine and then the relevant viva for that, upper limb, and then the relevant viva for that, etc. And then I'll take questions and discussion at the end. So again, you've seen this slide before if you were here last time. Just be aware of the terminology of movements. We're focusing on the left side of this screen today for the upper limbs, obviously. And we will be using this language, so hopefully you know all of that by now. If you don't, then you can go and watch the part 1. So again, general principles. Again, most of it is just look, feel, move, special tests. If you just remember that as your main framework for all musculoskeletal examinations, you will do well and you should pass. Okay. Obviously, don't cause additional pain, compare with the other side, and always do active before passive movements, as I said last time again. And that way you can see if the patient has any pain before you passively move it, so that you can be more careful with the patient. Again, same slide as last week, just look at the general status of the patient as well, mental state, body habitus, any arm slings, which is more relevant to this case today. Any medications on the side of the table, like steroids, and you always look for wasting, fasciculations, deformities, scars, swelling, discoloration, and that's for all the musculoskeletal examinations. And I won't talk too much about all of those today. So let's focus now on the spine exam. Obviously, you've got the cervical, thoracic, and lumbar regions. You should be familiar with them all by now, and the fact that you've got 7 cervical vertebrae, 12 thoracic, 5 lumbar, and then obviously the sacral. Be aware that spinal disease can affect multiple segments and not just confined to one space always. And patients can obviously present with pain or neurological symptoms as well. And understanding the anatomy can be important to working out where the pathology is. Although, of course, you can use imaging like X-rays and MRI, especially, to help you locate where that pathology is. So some specific spine definitions. You should be familiar with scoliosis, which is obviously the lateral curvature of the spine. Kyphosis, which is defined as the curvature of spinal sagittal plane with the apex posterior, which you can see here. You've obviously got a normal, a slight kyphosis normally in the thoracic region, but if this is pronounced, then you can have kyphosis. You can obviously get kyphosis of cervical and lumbar regions as well, which would be abnormal. And lordosis is the opposite, and you obviously normally have lordosis in the lumbar and cervical regions. But if you get lordosis of the thoracic spine, or if the lordosis is more pronounced in the cervical and lumbar regions, then that can be abnormal. Some of these other definitions, you don't necessarily need to know all of them and memorize them, but just be aware that they exist. Gibbous is basically where you have an anterior wedge deformity of a single vertebra. So the front of the vertebra is damaged. So the patient has increased forward flexion, so they're always looking like they're about to fall forwards. Spondylosis is quite a common word. You should know that. That just basically means degenerative change in the spine. And then spondylolisthesis is a bit more difficult one, but it basically just means one of the vertebra just slips forward on an inferior vertebra. And retrolisthesis is the opposite, where it slips backwards. And spondylolysis is where you get a defect in the pars interarticularis of the vertebral arch, which you can see over here, where you can have like a fracture going across here. Okay. But the main ones I've highlighted for you, scoliosis, kyphosis, and lordosis, you really should be very comfortable with those three words. So again, I'll be talking to you about how to look, feel, move, and then we'll go through the special tests. So first of all, anterior inspection. You should look for any scars. The most common one you may see in a spine exam is a scar here, which looks like this, which is a scar after an anterior cervical discectomy. And you look at the posture to see if there's any scoliosis, asymmetry of shoulder girdle, and if there's any pelvic tilt. And again, in the last talk, I talked about pelvic tilt and Trendelenburg sign, but basically it's due to hip abductor weakness or damage there. You look at the patient laterally, see if there's any abnormal kyphosis, lordosis. Posterior inspection, again, look at the spinal alignment. Is there any scoliosis? Look at the iliac crest alignment, again, looking if there's any dips in the hips. Muscle wasting, abnormal hair growth, bruising, etc. As long as you can sort of spiel out certain things to the examiner, as long as you always mention things like muscle, you're looking for muscle wasting, deformity, scar swelling, etc., then they'll be happy with that. So first thing in a spine exam, after you've looked anteriorly, laterally, and posteriorly, you can get the patient to walk, and you have a look at their gait. Again, I talked about this extensively in the last talk, so if you missed that, please go back and watch that. And then we get to feel. So you want to palpate all the spinal processes, starting at the top, the cervical region, all the way down to lumbar. And the spinal processes are basically the protrusions of the vertebrae towards the back. So you will feel it as a quite kind of sharp thing when you feel down the back. And you want to feel for the sacroiliac joints as well. This is obviously a posterior view. So from the back, you can feel the top of the hips there. And you're seeing if there's any tenderness or misalignment there. And then after feeling down all the way to the back, you want to feel for the paraspinal muscles alongside each side of it as well. Again, seeing if there's any tenderness or muscular spasms there. Then you want to, again, get the patient to do these movements. So flexion, extension, rotation left and right, and ask the patient to try and touch their ear to the shoulders each side to test for lateral flexion. These are the normal range of movements. Again, you don't have to memorize the angles specifically, but just to give you a sense of what is normal range of movement. And then you want to get them to flex and extend the lumbar spine as well with lateral flexion, as shown in these three pictures here. I thought that these diagrams showed patients who are a little bit overzealous, but this is how far you would want the patient to flex and extend. And obviously, when you're asking the patient to extend like this, you want to be standing behind them and just make sure that they don't fall backwards. And if you think the patient is unstable because they're confused, delirious, or dizzy, whatever, then you may opt not to do this at all. And you want to assess for a rotation of the spine as well. Most of the rotation happens around the thoracic spine. There is very little rotation around the lumbar spine. This is just a top-down view showing, but just see that they can rotate both right and left. So moving on to special tests. There are 3 tests you need to know about for spine. Sorry. Yes, 3 tests. So Schober's test is the first one, which is used to identify if there's any restricted flexion of the lumbar spine. Okay, so you want to locate the posterior superior leg spine, which is shown here. Okay, if you find it quite difficult to find this area, you can basically, it's about the same level as the anterior superior leg spine, which are the 2 bones sticking out of your hips at the front. So if you know where the level of that is, you can sort of work your way around the back, and then you should be able to find where the posterior superior leg spine is. Okay. Once you've located that bilaterally, then you want to make a mark in the middle of those 2. Okay, 5 centimeters below and 10 centimeters above. So you need to have a pen, and you make like an X 5 centimeters below that, and an X 10 centimeters above that. And then you ask the patient to touch the toes. You can use one of those sort of ruler strips to measure the distance. And when the patient touches their toes, the distance should increase from 15 centimeters, obviously 10 plus 5 is 15. It should increase to 20 centimeters or more. Okay. If it is less than that, then that can be a pathological sign. If some patients find it difficult to remember whether it's 5 centimeters below or 5 centimeters above, or is it 10 centimeters below, all I can say is you don't want to mark 10 centimeters below that line, because then you're getting close to another area of the body. Next test, sciatic stretch test, or also known as straight leg raise. This is to test the sciatic nerve, and if there's any irritation, obviously sciatica. You can see from this diagram that this sciatic nerve originates from these areas. So what you want to do is, obviously, again, you would have already got the patient to actively raise the leg to see if there's any pain there first, and then you passively raise the leg like so. With the knee fully extended. Normal passive hip flexion should be around 80 to 90 degrees. So you want to raise it all the way up to here. And once the hip is flexed, you dorsiflex the foot. So you push that way. on the foot. And the test is considered positive if the pain experiences pain in the posterior thigh or the buttock area, which is basically the symptoms which you'd expect from sciatica. Okay, and sciatica can obviously be caused by a lumbar disc prolapse, as an example. And the last test is the femoral nerve stretch test. Femoral nerve, this is an anterior view, obviously. It runs along here like so. And you want the patient to be lying prone for this one, because you obviously, it's sort of opposite to the sciatic nerve. So you want to be extending the hip joint. So you flex the knee at 90 degrees first, like this, and then you lift the hip joint up passively. And then you plantar flex the foot, so the opposite direction. So everything is opposite of the sciatica test. And this will be considered positive if there's pain in the thigh or the inguinal region. Okay. So for completion, you'd want to examine the upper and lower limbs. Okay, so joints kind of above and below. Yeah, and you want to do the neurovascular examination and obviously examine the MSK for both. And if further imaging is required, then you would do X-ray or MRI. So just moving on to the Viber case for the spine. I mean, ankylosing spondylitis isn't a common disease, but it's one that you're more likely to get in an exam situation, because these are patients who are stable. You're not going to see like trauma acutely in the exam situation. So ankylosing spondylitis is a seronegative spondyloarthropathy. Seronegative just means that it's rheumatoid factor negative, okay, and it's an autoimmune inflammatory condition. Basically, you get fusion or ankylosis of the spine and sacroiliac joints. Typically presents age less than 45, and it's associated with this HLA-B25 gene. And you will see that in your written papers. But if you know it for the Viva in an OSCE style exam, that will get you bonus points. Symptoms, typically you get this chronic pain in the back and stiffness, yeah. And you can also get other changes like uveitis, psoriasis. Alternating buttock pain is not pathognomonic or a hallmark of it, but it can be quite common in ankylosing spondylitis. And you can also get plantar fasciitis with this, and lots of other symptoms. Okay. So investigations, X-ray is probably the most common first thing you do. And you can sometimes see a bamboo spine or a dagger spine. Okay, bamboo spine is, I'll show you pictures of it in a moment, but it's basically where you get syndesmophytes, and classically described as paravertebral ossification running parallel to the spine, and dagger spine, which is linear ossification along the central spine. And I'll show you those in a moment. You can also do CT, but MRI is better. You can also do what's called bone scintigraphy, which is basically nuclear imaging technique of the bone, and this shows functional imaging. Okay, so it allows you to visualize bone metabolism or bone remodeling, and CT and MRI can't look at where the metabolism is occurring. Okay, so they normally use a radioactive agent like technetium with what's called MDP, which is methylene diphosphate. And then the areas of higher bone turnover basically light up black. This is a normal scan, by the way. But if you obviously get other areas lighting up, which is very dark black in color, then you know that there might be some pathology there. So on the left here is what a normal spine should look like, with nice gaps where the disc sits. and there's a clear gap between the vertebrae, but this is a bamboo spine where you get that ossification along the sides, so they will fuse together into one. Okay, and if you look at it from the lateral view again, this is a normal spine, very nice, clean, good vertebrae. On the right here, they've all sort of fused along the front here, and you can see all that calcification there. Okay, and just to show you dagger spine again, linear ossification of the central spine around the back, where you basically get interspinous ligament ossification, and it literally kind of looks like a dagger. So management, again, as with any viva you get, as I explained last time, always try to answer the examiner in this fashion. Say that you'd take an MDT approach, you'd involve the GP or family doctor, physiotherapist, occupational therapist, rheumatology. You try conservative first, educate patient, exercise, group therapy, etc. And if those measures fail, then you'd give medical treatment for pain, non-steroidals, steroid injections, and then you can move on to disease-modifying anti-rheumatic drugs, which include sulfasalazine, methotrexate, in the second line, ethanacept, infliximab, etc. Okay. Surgery is not normally done in ankylosing spondylitis, but if you get some complications like fractures, or if you need some certain joint replacements, then you may need to involve surgery as well. But basically, this slide, you're going to see this a few more times today, because in all rheumatology or musculoskeletal related disorders, this is pretty much the same for most of them. Moving on now to the shoulder. I showed you these pictures last time, but I just want to refresh it in your memory again. The rotator cuff muscles, these four here, are important for you to know about. You can use the acronym SITS to remember them, SITS, which include the supraspinatus, subscapularis, teres minor, infraspinatus. Again, don't memorize the name, like the functions to the name. Memorize where they are and where the anatomy is, and then you'll know what the functions are. So again, subscapularis, this is an anterior view. So it's this big muscle here. So if that was to contract, then obviously your shoulder will internally rotate. This is the posterior view. So same on the back, the infraspinatus and the teres minor, if they contract, then you're going to externally rotate the shoulder. And the supraspinatus, which sits sort of higher up here around the back. You can see a bit of it in the front view here. This is also part of the supraspinatus. If that contracts, obviously your shoulder is going to abduct and you can lift your arm up. So really learn the anatomy, and then you'll know the function without having to memorize anything. So again, look, feel, move, special tests. Again, anterior inspection, same as before, really, scars, bruising, asymmetry, swelling, etc. Nothing really too special to talk about here. And just look at the deltoid area, the muscles of your shoulder here, upper arm, and see if there's any wasting there. Lateral inspection, posterior inspection. One different thing about the posterior inspection of the shoulder, you want to look for a winged scapula, and you can get the patient to sort of put their hands against the wall and push and look at the scapulae here and see if there's any asymmetry there. And if it can be a sign of long thoracic nerve injury. Okay. Feel, I didn't put this in all slides, but always feel for temperature, because you want to rule out septic arthritis or inflammatory conditions. And then you move on to palpation. I sort of added these bits myself. I think it's good to be able for you to be able to see it all on one slide. But basically, it's quite easy. You just start here at the sternoclavicular joint, and you just work your way around. You just palpate around I mean, most of the time the examiner probably won't know exactly what you're feeling for anyway. So if you forget, just palpate along confidently, and he or she will think you're doing the right thing. Okay, so you start here at the sternoclavicular joint, and you palpate the clavicle, you move along here, you palpate the AC joint, and the coracoid process of the scapula, head of humerus, greater tubercle of the humerus, which you can also palpate it from the side, and then finish off with the spine of the scapula along here. Okay. Move. So the first things you want to do in the shoulder exam in the movement part is you want to do compound movements, which is a rapid screening tool. At this point, I want you to think of the police, because the two movements you're going to do are basically this and this. So I thought it was quite good for you to remember it like that. So this one, obviously, put your hands behind your head and push your elbows back, is testing external rotation and abduction of the shoulder joint, and putting hands behind the back. And actually, you do need the hands to be a bit higher up, but it's similar to being handcuffed. And that tests obviously internal rotation and adduction of the shoulder joint. It's a bit weird to think of this motion being internal rotation, but if you do it yourself, put your hands behind your back, then you'll sort of feel your shoulder moving forward as you do that motion. Okay. And then more, obviously, the more focused movements, again, active, passive, flexion, extension, which you can see here. You get the patient to abduct, and adduction, you want to bring that arm sort of towards the other side, so they're crossing the midline. And then you want to get them to do external rotation and internal rotation. And you also want to assess for scapular movement. So you go around the back, you place your hand at the bottom of their scapula there, and you ask them to raise their hand, and you're feeling for the scapula there. Okay. Special tests are basically just to test the different rotator cuff muscles that I talked about. So the supraspinatus, again, that's the one abducting the arm. You can assess that using the empty can test or Joby's test. You basically abduct the arm 90 degrees, so you lift the arm up, and then you angle the arm forwards 30 degrees. So you might need to see my arm here. So out to the side, slightly forward, and then internally rotate the arm, thumbs to the floor. Okay, so they're basically doing this, all right? And then you push down on the arm, and the patient resists that motion. And you obviously need the supraspinatus to keep your arm in that position. Okay. Next test is called the painful arc test, which is looking for impingement syndrome. Again, this is a test for supraspinatus. So you passively abduct the arm to maximal abduction. So you basically lift up their arm all the way up to here for them. And then you ask the patient to lower their arm slowly down. And painful arc normally occurs typically between 60 and 120 degrees of motion here. Okay. So if you do get pain there, then it's positive for supraspinatus tendinitis or impingement syndrome. Okay. And impingement syndrome is basically inflammation of the tendons of the rotator cuff muscles as they pass through the subacromial space. Okay. And just to quickly mention, this test is not specific for supraspinatus tendinitis or impingement syndrome because other pathologies can give you pain in that range of movement, like osteoarthritis and adhesive capsulitis, etc. Now moving on to the infraspinatus and teres minor, which are responsible for external rotation of the shoulder. So you want to externally rotate against resistance. So you get them to flex their elbow 90 degrees, and then in slight abduction, so slightly lift their shoulder up, and then you passively rotate their arm out. And you put pressure on that arm. Sorry, you can't see my arm, but you put pressure on that arm moving out. And if they have pain in the back area where the infraspinatus and teres minor is, then that is a positive sign, and it can mean you've got infraspinatus tendonitis there. And then you want to do external rotation in abduction, which tests the teres minor. So it's the same muscle here, but it's just testing that teres minor by itself. So again, arm 90 degrees abduction, so arm 90 degrees out, and then bell the elbow 90 degrees. So you're like this. So when you're in this position, you passively externally rotate the arm up like this, and then you want to push forward on that arm while the patient resists. And if they get pain in that back, in the teres minor area, then it's called a hornblower sign, which is inability to keep your arm in that position, and it can mean you've got teres minor pathology or an axillary nerve lesion. And I've shown you here where the axillary nerve lies. It's part of the posterior cord of the brachial plexus, and then it comes off here. And in this image, you can sort of see it. This is the posterior cord coming around the back here. Okay, so that's then the axillary nerve, and then it obviously branches off and goes to the teres minor muscle, etc. So yeah. I'm not going to go into the depths of the anatomy of the brachial plexus here, but you need to learn that. Another one, internal rotation against resistance. It's also called Gerber's lift-off test. I've been smart, and I've added an image this time, so I don't have to move around myself. But this is basically to test the subscapularis around the front of your shoulder. So you place the dorsum of the patient's hand on their back, and you apply light resistance to the hand here, and you ask the patient to lift off the hand from their back. And if they're unable to do that, it can mean a subscapularis tendonitis or a tear there, and it can also indicate a subscapular nerve lesion. Scarf test. This is to assess here the acromioclavicular joint. So you passively flex the shoulder 90 degrees up, and then you place their hand onto the contralateral shoulder, so like a scarf around the neck. And if you get pain in that joint there, it's positive, and it can indicate osteoarthritis. For completion, you want to do a neurovascular exam of the upper limbs. Examine the joints above and below. You can consider cervical spine as above, and you'd examine the elbow. And if you need further imaging, X-ray or MRI. So shoulder fiber, obviously you can get osteoarthritis fiber for shoulder as well, but since I spoke about osteoarthritis in the lower limb talk, you can refer to that talk to look at osteoarthritis. But I'll talk a bit about adhesive capsulitis, which is quite a common condition. And again, patients are stable, so you're likely to see that in exam situations. It's also known as frozen shoulder. Okay, it's characterized by thickening and contraction of the shoulder joint capsule and surrounding synovium. You typically get shoulder pain and stiffness, and it's diagnosed clinically with history and examination. It does have some association with diabetes and hypothyroidism. And this is just an image, just to show what it might look like, but I don't want you to focus too much on the image. This is quite a busy slide. Again, I don't want you to memorize all this stuff, but I just want you to know there are 3 stages to adhesive capsulitis. There's the freezing, which is the painful stage, frozen, which is the transitional stage, and then the thawing stage where it starts to improve. So the freezing stage, so patients might not think it's anything too much. It's a bit uncomfortable. They don't present to the doctor because they just think it will go away. And they start to get worsening pain in both active and passive movement and reducing range of motion. And this typically lasts 3 to 9 months. And just note that these phases get longer and longer. Okay. And it's characterized by the acute synovitis of the glenohumeral joint, the shoulder joint. And then you get into the transitional stage where the pain does not necessarily worsen, but because it is painful, you're not using your shoulder as much and you might get muscular disuse. And this can typically last between 4 to 12 months. You get progressively diminishing motions. External rotation of the shoulder is most limited, followed closely by shoulder flexion and internal rotation. And eventually, towards the end of the transitional stage, pain does not occur towards the end of the motion. And then the thawing stage, range of motion starts to improve. This can last quite a long time and eventually get a gradual return of shoulder mobility. So it is a self-limiting condition. It does get better sort of by itself, but you can obviously do a lot to help the patient symptomatically. It can be quite debilitating for the patient, especially if they have a job which requires them to use their arms a lot. This is just a nice picture just to show, obviously the months here written are a bit different from here, but it's similar. And it just shows that pain increases during the freezing phase and then starts to come down thawing, and it's opposite direction to the range of movement. Okay. So just learn the different stages and this graph and you'll be fine. As I warned you earlier, pretty much same management. You say MDT, GP, physiotherapy, occupational therapy, rheumatology, and orthopedics if required. Conservative management, again, like education, exercise. I mean, exercise has limited evidence in adhesive capsulitis, and you obviously don't want to over-exercise it because it might make it worse. But physiotherapists may be able to give them sort of specific, specialized exercises to do. Medical, again, non-steroidal inflammatory drugs, corticosteroid injections. There is something called glenohumeral hydrodilatation, which again doesn't have the strongest evidence, but it's thought to help in some cases. So typically the shoulder joint contains about 8 to 15 milliliters of fluid, but in adhesive capsulitis, the amount of fluid can decrease because of all the pathophysiological changes that happen and fluid moving out, etc. I'm not going to go into the detail, but basically you can inject a little bit of contrast to the area to make sure you know where you are, and then you can give some local anesthetic with steroid and then fill it up with water, hydrodilatation. So restoring the normal sort of water volume in the shoulder joint there, and that's sometimes proven to give relief of symptoms to patients. And then if all of those fail, you can consider surgery, which includes closed manipulation of the shoulder joint under anesthesia, or basically cutting adhesions for prolonged severe cases. But that's not commonly done. But as long as you remember this MDT conservative medical and say it's corticosteroid injection, you're pretty much there. Moving on to elbow exam, which is probably the easiest one. And because it's a bit too easy, you might not, it's unlikely you'll get this in the exam. But anyway, we should go through it because you may get it. So again, look, feel, move, special tests. Anterior inspection, same as before, scars, bruising, swelling. etc. One thing that's different for the elbow is you want to look at the carrying angle. So normally your arm has this angle here, from here to here, okay? And that's typically 5 to 15 degrees. But you can get a slight varus or valgus deformity, okay? Varus, remember from our last lecture, you can remember it with varus eovorus. If you don't get what the hell I'm talking about, go and watch my other lecture. So cubitus varus is also called a gunstock deformity, and it can be caused by a supracondylar fracture of the humerus. And the cubitus valgus, it can be caused by either previous elbow joint trauma or congenital deformity such as Turner's syndrome. But don't worry too much about memorizing that. It's not going to be whether you pass that exam or fail is not going to be due to you knowing or not knowing about the carrying angle. Again, lateral inspection, posterior inspection, scars, fixed flexion deformity, muscle weighting, etc. As I mentioned in my last talk, on the elbows, you want to look at the rheumatoid nodules, which can occur typically here on your elbow, which basically just looks like a lump. And you want to look for psoriatic plaques as well, for psoriatic arthritis. So moving on to feeling for the elbow, again, temperature for psoriatic arthritis, inflammatory arthritis, is all the same things. Then you want to palpate the radial head, just here. This is obviously anterior view of the right arm. So head of radius, then the radiocapitellar joint here. Then you move on to palpate the lateral epicondyle, the olecranon, which is around the back, and then the medial epicondyle. So anterior view, posterior view, okay. And then with the elbow flexed 90 degrees, you want to palpate in the antecubital fossa for the biceps tendon and see if there's any tenderness there, anything like that. Again, active, passive. Because it's a simple hinge joint, you're only really going to be able to do flexion, extension, but because you've got these dual bones here, they can pronate and supinate. So you just ask the patient to do that. Special tests, there's only two. One is medial epicondylitis, also known as golfer's elbow, and the other one is obviously lateral epicondylitis, which is tennis elbow. I'll talk about golfer's elbow first. It's called golfer's elbow because it can typically happen in people who play golf, but it's not only limited to golfers. It can occur in lots of other jobs or whatever, or trauma. And to test this, you basically do active wrist flexion against resistance. Diagram here for you to see. So you flex the elbow to 90 degrees. You palpate the medial epicondyle, which is around, he's palpating with his thumb around the back there. You hold the patient's wrist with the other hand. You ask the patient to make a fist and flex the wrist while you apply resistance. And if there is pain over the medial epicondyle as they flex that wrist, then it's suggestive of medial epicondylitis. Before I talk about lateral epicondylitis, I'll just quickly show you one slide of elbow fiber. So medial epicondylitis is basically an angiofibrotic tendinosis of the common flexor pronator tendon group of the elbow, which are shown in this picture here. So you get pain here, and it mainly composes of these tendons and muscles. Diagnosis is obviously clinical, but you can use X-ray, ultrasound, and MRI to help you. Treatment, if you do get it in the Viber situation, same as before, talk about the MDT, conservative, medical, surgical, etc. And obviously rehabilitation, NSAID, steroid injection, and surgery if required. Okay, you won't be required to know the specific surgery they do. Opposite side, lateral epicondylitis or tennis elbow. Again, it doesn't only happen in people who play tennis. And this is active wrist extension against resistance. So you flex the elbow to 90 again. You're palpating the lateral epicondyle this time, again palpating with your thumb. You hold the patient's wrist with the other hand, and you ask them to make a fist and extend the wrist while you apply resistance. If they get pain when they're extending, then it's positive for lateral epicondylitis. Sorry, if they get pain over the lateral epicondyle. And a bit of tennis elbow Viber. It's basically overuse syndrome of the common extensor tendon, and predominantly affects the extensor carpi radialis brevis, or abbreviated to ECRB tendon, which I've circled here nicely for you. Well, that's goes along here, so you get tenderness along here. And same as before, clinical, X-ray, ultrasound, MRI, treatment, rehabilitation, and steroid injection surgery. You can also consider a splint or a brace for tennis elbow. You're starting to get the hang of treatment and all this for MSK, hopefully now. Always the same. Completion, examine joints above and below, which is shoulder and wrist. Full neurovascular examination of limbs, X-ray, MRI. Again, same. Hand and wrist exam. This is a big one. I would say out of the upper limbs, this is probably the most likely one you're going to do because it's the most complicated. And it's very easy to find patients for this because the most likely pathology you're going to be getting presented with is rheumatoid arthritis, and rheumatoid arthritis most of the time is quite stable and they're in remission. You can also get carpal tunnel syndrome. So this is the most likely upper limb exam you're going to get, and it's the hardest. So focus for this one. Again, the basic principles are the same: look, feel, move, special tests. But as you can see from this slide already, there's a lot more going on. By the way, when you start practicing together with your friends and you sort of get quite comfortable doing the examinations and things, these slides that I've made for you, the look, feel, move, special test, this might be a good slide for you to print out as a sort of checklist for when you get more comfortable. And then you can just use this slide to remind you everything that needs to be done. So look, when I show you all these, obviously don't forget the general look in the exam as well. You know, looking at the general state of the patient, the GCS, the posture, everything around the bed. Don't forget to do those things. And then you want to look at their hand posture. Is there any dupitant, contractual, ulnar deviation? Any scars, swelling, erythema, bruising, skin thinning? Skin thinning obviously due to steroid use, psoriatic plaques, muscle wasting, splinter hemorrhages, and more specifically regarding rheumatoid arthritis and osteoarthritis, you're looking at Bouchard's nodes, Heberden's nodes, swan neck deformity, Z-thumb, Boutonni's deformity, and neopatinolicolysis. I will show you pictures of them. I've shown you most of these last time before, but just to go over again. In osteoarthritis, you can get Heberden's nodes, which occurs at the distant phalangeal joints, Bouchard's nodes in the proximal interphalangeal joints. In rheumatoid arthritis, this is the one you need to focus on. You get that ulnar deviation. Okay, this is a Boutonnier deformity of the finger, swan neck deformity. There are better pictures of swan neck deformity actually, so you should Google them and see what they look like. But it basically looks like a swan's neck. This is the Z-thumb. Obviously, yeah, it does look a bit like a Z. Where basically, because you've got flexion here, hyperextension here, and flexion here, that's what causes the Z shape. But no one's going to ask. Don't worry. Psoriatic arthritis, which is very unlikely you're going to get that in the exam, but you're looking for nail pitting, onycholysis, which is splitting of the nail. And you can get white nails as well, which is leukonychia. Just in case they give you carpal tunnel syndrome, look at the thenar and hypothenar eminence. This area of the palm is the thenar, and this area here is the hypothenar. Okay, so this is normal hand, and here you can see thenar atrophy. Okay, and finally, don't forget to inspect the elbows again for the rheumatoid spondyloarthropathy nodules. Actually, when I do the hand and wrist exam, I like to look at the wrists first. The elbows first. So I just get them to raise their arms up like this, just quickly have a look at the elbows. Then I can focus on the hands and just forget about the elbows entirely. Because if you start with the hands and then you move on to palpate and things, you'll forget about the elbows. So, feeling. There's a lot of feeling you need to put into hands. First of all, palmar, so you get your patient's hands up this way, not this way, so up like this. You need to palpate for the radial and ulnar pulse. Remember, ulnar pulse, you might not feel it at all. It's difficult to feel even in a sort of young, healthy, lean patient. Sometimes you might not even feel the radial pulse in very sort of obese, frail patients. And this may cause you troubles once you become a junior doctor and you're asked to do the ABG, but you'll understand what I mean later. Again, look at the thenar, hypothenar, muscle bulk. For these things, you just quickly look at the Dupuytren contracture, and then you want to test for median nerve sensation using like cotton wool or bit of tissue, whatever. And you can see the distribution of the median nerve sensation here, and it goes to half of the ring finger, and ulnar nerve sensation out here. And then the dorsum of the hand, okay, you want to test the radial nerve sensation, okay, which is in the first dorsal web space, which is around here. You do an MCP joint squeeze, so you squeeze all the hand together like this. And if there is tenderness there, it can be a sign of arthritis. And then you basically palpate every single joint. So you palpate all the dips, all the pips, all the MCPs, and all the CMCs. So that can take you quite a long time. But the examiner doesn't want to see you going too slowly, but also not too fast. You need to make sure you convince the examiner that you are feeling every single joint properly. And you want to use like a pincer grip. You want to hold the joint and you want to sort of wriggle it a little bit. Every single joint, just give it a little wriggle, like so, okay? That way you convince the examiner that you are actually palpating it properly. You also want to palpate around the anatomical snuff box around here, because the scaphoid bone, similar to the neck of femur fracture, they have a high chance of avascular necrosis if there is a fracture there. So that's an important finding to rule out. And just palpate their wrists as well. Okay. And feel the elbows if you want to. Movement, active before passive. So you want to get them to flex and extend all their fingers. Okay. But for this part, don't do every finger individually, because then that will take forever. So just get them to do all the finger extensions at the same time, and then all flexion at the same time. And then you ask them to do the prayer sign and the reverse prayer sign, as you can see here, to test for wrist flexion and extension. And after you've done that, passive movements, okay? So you basically want to show the examiner that you're doing tests for the radial nerve, ulnar nerve, and median nerve. Motor functions. This is different from sensation, okay? So don't get confused. So that's what you want to achieve, okay? So you show the examiner you're testing for the radial nerve by doing wrist and finger extension against resistance, as shown here. You place your fingers like so, you hold their wrist, and you ask the patient to extend their wrist and the fingers. And you're obviously feeling for power. To test the ulnar nerve, you want to test index finger abduction, but it's quite difficult just to test the index finger on its own. So you just get them to splay all their fingers out, and you place your hands like this, and you apply a little bit of resistance and check their power. And to test the median nerve, you get them to abduct their thumb, which in abduction, in the case of the thumb, is sort of like an upward motion. Sorry, the other way. You want them to move their thumb out. So you place your thumb here like so, and again, a feeling for their power. And if the power is weak, you are testing for this muscle here, abductor pollicis brevis. And on top of all those movements, you need to do quick function tests as well. So power grip, squeeze my fingers, pincer grip, squeeze my finger with your thumb and index finger. And you can ask them to pick up a small object as well, like a coin or a button. Some students like to do the function part before the other movements. I personally like it because it's kind of like, you know, with the shoulder, we did that rapid screening test with the police. It's kind of like that. So I would actually do these first, but it's up to you. You can also say to the examiner that you would like to see how the patient writes with a pen, because you can rule out other pathologies with this, like Parkinson's disease. You get micrographia, small handwriting. So you can say that to the examiner. And sometimes also, remember when I told you about make sure you look around the patient. There should be clues around the patient as to what the examiner actually wants you to do. So for my exam, for example, there was a piece of paper and pen there, and there was a button there. So make sure you look, okay? But chances are the examiner won't want you to get the patient to write and stuff. There's just a lot to do in this exam. Special tests, Tinel's test. This is to look for carpal tunnel syndrome. You're basically testing the median nerve if there's any compression there. You basically just tap over the carpal tunnel, which is here, the wrist. You just tap like this. Not too hard, but and if the patient gets tingling in any of these areas in the region of median nerve sensation, then you got median nerve compression. Phelan's test, you do that by holding the wrist in maximum forced flexion, kind of like it is like the reverse prayer sign, and you hold it there for 60 seconds. Again, this is a test for median nerve compression and carpal tunnel syndrome. So if the patient starts to experience their symptoms of carpal tunnel syndrome, such as burning, tingling, numbness in the thumb, index, middle, and ring finger, or half the ring finger, then that's a positive test. So the special tests are only for carpal tunnel syndrome, not for rheumatoid. So for completion, obviously there are no joints below, but you'd examine the joints above. So you'd examine the shoulder and elbow and neurovascular examination. Well, technically you've done the neurovascular examination of the hands, but you would, because you've felt for the radial and ulnar pulse and you've done the sensation of the radial and ulnar nerves, but you want to check the pulses of the elbow, etc. And again, X-ray, MRI. So hand fiber, most likely one you're going to get is rheumatoid arthritis. So you need to know about it very well. It's a chronic autoimmune multisystemic inflammatory disease. It's a bit of a mouthful, but just learn it. It can affect many organs, but primarily the synovial tissues and joints, and typically the smaller joints of hand and wrist, but it can affect the foot as well. Females are affected more than males. There are some risk factors like smoking, obesity, and low socioeconomic status. Smoking has more relevance to seropositive RA. And there's association with HLA-DR4. Again, just a hint, that's a good one to memorize to impress the examiners. Clinical presentation, there are obviously the articular features, the joint, pain, stiffness, and all those Boutonniere deformity, swan neck deformity, all that stuff that I talked about already. But there are lots of extra articular features as well, because it affects many other organs. And I did go through some of them in the last lecture. So eye changes and changes in the lungs, etc. But I'll go through them again in a moment. The presentation can initially be quite insidious, or it can be very abrupt. Okay? And it can be, the early features can be just general things like tiredness, malaise, general aches in the body. Okay. Oh, and also, other than the things I just mentioned about the Boutonnieres and swan neck, etc., I just want you to know that the definition is a symmetrical deforming peripheral polyarthropathy, so it affects many joints. Okay. And it has the classic inflammatory phenotype, so you get the stiffness, reduced range of motion, reduced function. It has a boggy feel to palpation. The extra articular features, again, don't worry about memorizing everything, but just know that it affects all these other areas of the body. For in the lungs, interstitial lung disease, this is a good one for you to memorize for exams. Examiners will want you to know that. It can accelerate atherosclerosis, gives you these rheumatoid nodules in the elbow, as I said earlier, but it's typically in the pressure areas. Felty syndrome is also another one that examiners will be very impressed if you know about. And that's basically where you get a triad of rheumatoid arthritis, splenomegaly, and neutropenia. If you can actually sort of bait the examiner into getting you to say this, because after you do the hand and wrist examination and they say, how would you complete the examination? You can also add to all the other stuff I said earlier about examine the upper limb and stuff. You can say, I would also feel for a splenomegaly. If you say that, they will say, oh, why did you say that? Then you say, because I want to, if it is rheumatoid arthritis, I want to rule out Felty syndrome. And then they'll ask you about Felty syndrome. And then you basically mention these things. And then they'll be very impressed and you'll get top marks. And eye changes, as I said last time. Okay. So I think another thing for you guys to take away from my talks is you can actually guide the examiner into talking about stuff you want and impressing them. And there are ways to do that. And as you gain more experience, you'll get better at doing it. But when you're practicing with each other, think of ways like this that you can get the patient, the examiner to go where you want. Okay. Diagnosis. It's a combination of clinical, serological, and radiographic. I would say more clinical and serological, so focus on those. In 2010, the American College of Rheumatology and European League Against Rheumatism, ACR-EULAR, made a classification criteria for rheumatoid arthritis. Again, you don't necessarily have to memorize this whole thing, but just know that it includes joint distribution, serology, and symptom duration. And it has a maximum of 10 points. So a maximum score of 10, because you can only have one from here, one from here, and one from here. So maximum score of 10. You need more than 6 for diagnosis. Okay. And I mean, this is quite easy in the sense that you just need to know if it affects more joints, you get more points. If they're positive for the rheumatoid factor and anti-CCP, or the Americans like to call it ACPA, it's the same thing. Then obviously you get higher points, and longer duration, higher points. As you know from your revising for your paper exams, obviously rheumatoid factor was the sort of first main one we used to use, but it's non-specific for rheumatoid arthritis. It can be positive in many other conditions as well. So you can't diagnose rheumatoid arthritis with rheumatoid factor alone. Anti-CCP or anti-cyclic citrullinated peptide, or ACPA, which stands for anti-citrullinated plasma antibody, it's the same thing. It's a lot better. It's more than 80% sensitive and more than 95% specific. So more than 80% chance that you'll pick up rheumatoid arthritis with this. And once it's positive, you can be more than 95% confident that you've got the right diagnosis. And you obviously get increased CRP and ESR as well. So management, again, same format, MDT approach, GP, physiotherapy, occupational therapy, rheumatology, conservative, exercise education, medical for pain, non-steroidals, and in order to get a patient into remission from an active disease, you probably need to use DMARDs, disease-modifying anti-rheumatic drugs. These are typically going to be prescribed by the rheumatologist, not a GP or an acute medic. So you need to make a referral to rheumatology, and they will try all these kind of different drugs, either conventional. You'll see a lot of patients on methotrexate or leflunomide and prednisolone for more acute phases. Obviously, you don't want patients to be on prednisolone for long periods of time because of Cushing's disease and these other complications. And with methotrexate, you obviously need to be careful for neutropenic sepsis. And they can consider TNF-alpha inhibitors like infliximab, abatacept, rituximab, and all these other things. This is one that I haven't seen used, but it's there. So just know about some of them, and just say that the rheumatologist will most likely prescribe and start the patients on these. You don't need to worry about when you would start them on various factors, okay? And surgery is just if they require joint replacement. If it starts affecting their larger joints like the knee, sometimes the hip, for example. Okay, so in summary, we've gone through the examinations of the spine, upper limb, and the hands, and the relevant anatomies that you need to know. about each one. We've gone through some viable cases of ankylosing spondylitis, adhesive capsulitis, and rheumatoid arthritis. I would suggest for hand, you should also know about carpal tunnel syndrome, read up a bit more about it. And obviously you can get osteoarthritis of the shoulder coming up as well. Sorry, I didn't add it there, but we also talked about the golfer's elbow and tennis elbow. So once you know about those conditions, you should be quite well set for the exam. Any questions or anything like that? I hope that was useful for everybody.
So there's nothing in the chat.
Okay.
I'm just checking YouTube as well. Guys, you can also feel free to unmute yourselves if you'd like to ask a question directly. Yeah, there's nothing on YouTube. So
okay, then thank you very much, everyone, and I'll give you the next slide. Oh, there's one thing in the chat. Oh, okay. No, it's just yeah. Thanks.
Yeah. Yeah. So I will just grab the feedback link.
Mm-hmm.
So yeah, guys, if you can please just fill in the link, it's really helpful, not just for us, but also for Dr. Bay as well. So this is the chat. I've just put it in the chat. So yeah, guys, we've got two more great lectures that are coming up to finish this series. So next week we've got dermatology. That's happening on the 19th, and then we're going to wrap up with emergency med exam. So how to perform that, and that's going to be our final one. So we're going to really aim to end on a high. We're going to do this giveaway at the end. So yeah, this is our next lecture. Could you give the next slide, please?
Yeah.
Fantastic. So yeah, guys, you can use the QR code here, as you guys already know. I've also pasted the link in the description as well. So feel free to fill that in. Please fill that in. It gives us all really great, feedback on what we've done well, what we can improve on for next year. And yeah, thank you guys for coming. And yeah, if you guys are free to head off, enjoy the rest of your day. Thank you so much, Dr. Bay, for giving up your time.
Yes, thank you for inviting me.
Yeah, no worries, no problem at all. Okay, fantastic. So I'll end the call now. So thanks very much, guys, and I hope you guys